Okay, well, let's begin. So I want to go over this case study called Coronavirus Disease 2019, a favorable outcome in an immunosuppressed patient with multiple sclerosis. So here we have someone who was on medication that suppresses their immune system, and it turns out, luckily, this person ended up not having a severe, or I should say, they had a favorable outcome in regards to catching coronavirus, which is great because they're immunosuppressed. And we've been going around saying that we really need to care about immunosuppressed people because they're going to be at higher risk for dying from the coronavirus. But luckily, it appears as though even if you are immunosuppressed, there is still a good likelihood that you are going to have a favorable outcome. So here, let's go over what what happened at this clinic. So, abstract: the rapid and global spread of severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, which is a viral pathogen responsible for the development of COVID-19. This has developed into an unprecedented health crisis with considerable case fatality rate. Patients with comorbidities are considered to be at higher risk for severe disease, and this is how all diseases work. All diseases, if they end up causing mortality, it usually is taking advantage of the fact that you are in a partially weakened state. So we have been very concerned about people, especially with lung-related issues. But it turns out there are only a subset of comorbidities that are actually contributing significantly to death. So, for instance, I think heavy smoking doesn't increase the risk of developing COVID-19, but if you do develop COVID-19, then you end up having a more severe outcome afterwards. Regardless, let's continue. So they are considered to be at higher risk for severe disease with acute respiratory failure, ICU admission, and/or death. Particular vigilance has been warranted regarding the continuation of immunosuppressive treatment. So we have been, a lot of caregivers, or a lot of clinics have been warned about the use of immunosuppressive treatments during a pandemic, because if your immune system is suppressed, it might end up screwing you over later. Anyways, since viral clearing may be hampered in such cases. So in contrast, it has also been hypothesized that overreactive immune responses may trigger a cytokine storm associated with clinical deterioration, which has generated an interest in certain immunosuppressant drugs as potential treatment for COVID-19. So, for instance, you might have heard of dexamethasone. That is a steroid, and steroids frequently suppress, steroid and corticosteroids. Those will suppress the immune system, and so they're suppressing inflammation, but that is the result of suppressing the immune system. So perhaps the correct timing of when you give these drugs to people, that could also play a very large role in making sure that the immune system is suppressed when you need it to be suppressed, but active when you want it to be active. Now, the problem with someone with multiple sclerosis that is on an immunosuppressant drug all the time, that timing isn't there because they're just always on it. And so there is a concern that if you're always on an immunosuppressant, that you are going to have a more severe outcome near the end. So let's continue. We would like to present the first case report of a patient who was formally diagnosed with COVID-19 while being under disease-modifying treatment with rituximab. And I don't know how to pronounce this exactly, but rituximab. And this is an anti-CD20. So the receptors, so your white blood cells have a lot of receptors on them. And so there is a subset of white blood cells that have the CD20 receptor. And so rituximab is an antibody that is against or will react with CD20, and this reaction, or I should say this interaction, focus, this interaction will cause the B cell to kill itself. So basically, once the antibody interacts with CD20, which is one of the receptors on the B cells, the B white blood cells, it then convinces the B white blood cell to kill itself. And so this is good if you have multiple sclerosis and you are getting, if the reason why you have multiple sclerosis is because you are producing antibodies against the myelin sheaths of the neuron cells, or you're basically creating antibodies that are attacking your nervous system, oftentimes rituximab is given to people to kill the excess or a lot of the B cells, the B white blood cells, and that in turn allows the nervous system to not be attacked by the immune system as much. So the clinical picture was mild, for which we have tried to provide an immunopathological framework. So here is the case presentation. Oh man. Kind of stuff up right now. So, a 33-year-old female patient with relapsing onset multiple sclerosis was electively admitted to the Belgian National MS Centrum for Neurological Assessment and Multidisciplinary Rehabilitation. A lot of big words. They're just trying to get a bunch of different people with different specializations to assess her neurological condition on March 9th. So such programs are covered by the local reimbursement system and considered to be part of the standard medical care. So this isn't someone with a load of money that is able to go into an extremely specialized facility. This is just part of standard care. So they're considering this is a standard procedure, a standard mode of operation. Anyways, she was diagnosed with multiple sclerosis in 2004 following an episode of optic neuritis of her right eye. So neuritis, I believe, is inflammation of the eye, or inflammation of the nerves, but inflammation of peripheral nerve or nerves, which is usually causing pain and loss of function. So she had this in her right eye, and she had subsequent relapses, which resulted in spastic paraparesis. And paraparesis is the partial paralysis of both legs. So, and it's characterized by progressive weakness and spasms of the leg. So she had spastic paraparesis and cerebellar dysfunction. So remember, the cerebellum is a part of the brain. And it was presenting with truncal and appendicular ataxia. So ataxia is when you are not able to move correctly. So it's a degenerative disease of the nervous system, and it's basically mimicking being drunk. So this person had it in her truncal and appendicular areas. So what is a truncal area? I believe it's your trunk of the body. Yep, trunk of the body, or so your middle part. And then the appendicular areas as well, which I believe are the limbs. Yeah, so the limbs. So, it'd be nice if they just said in the trunk of the body and in the limbs, but, it's a clinical paper. You have to use clinical terms. So, off-label disease-modifying MS therapy with rituximab, which is an anti-CD20-mediated B-cell depleting agent, was given as a single intravenous course of 1,000 milligrams on October 11, 2009, after a period of disease progression with clinical and radiological inflammatory activity. So, despite treatment with subcutaneous interferon beta 1A, let's see. So here they gave her a single intravenous course. So I think this appears to be a drug that is given once, or at least rarely, and it's given in a dosage that ends up killing a bunch of cells during that injection, and then after that you end up receiving the benefit of it. So, and she was being treated with under the skin, so subcutaneous interferon beta 1 alpha, which I believe is a different immunosuppressant. So let's look this up. So yeah, interferon beta 1 alpha is another, it's a cytokine, but I assume it is an anti-inflammatory cytokine. So when we talk about the cytokine storm, there are both pro-inflammatory and anti-inflammatory cytokines. So it's all regulatory mechanisms. And so interferon beta 1A is, I would assume, one of the anti-inflammatory ones. So yeah, so it balances the expression of pro and anti-inflammatory agents in the brain and reduces the number of inflammatory cells that cross the blood-brain barrier. So overall, therapy with interferon beta leads to a reduction of neuron inflammation. So yes, this is one of the anti-inflammatory cytokines. So she was being given subcutaneous interferon beta 1A, but she was still having her disease in multiple sclerosis was still progressing. So rather than just giving her a cytokine to help control her multiple sclerosis, they ended up giving her a high dose of this. I don't know if this is high or not, but they gave her a dosage of this drug, and I forget the name of it. What was it called again? Boxtimnabab or something like that. Oh, rituximab. So yeah, it was a one-time, I shouldn't say one-time because they might do it again, but they gave it to her. And this kills a big part of her immune system. It's immunosuppressive. So they did that, and let's see, expanded disability status scale score was 8 at the time. So this is just a disability scale that can help quantify how disabled someone had become. So it's the EDSS scale, and it ranges from 0 to 10 in 0.5 units. And scoring is based on an examination by a neurologist, and EDSS steps 1 to 4.5 refer to people with MS who are able to walk without any aid, and it's based on measures of impairment of 8 functional systems. So here, actually, I'm not going to get the graph up because I don't want to put on copywritten material. So let's continue. So her score was 8 at the time, so that's approaching the middle. So remember, 1 would be a healthy person that can walk without any issues, and 8 would be decent. And I would assume if you are, oh yeah, it goes from 0 to 10. So yeah, 8 would be pretty severe at the time. Anyways, she remained stable ever since. And so 7 days after admission, our patient developed fever, muscle soreness, headache, productive cough, and mild dyspnea. So dyspnea, I believe, is difficult or labored breathing, so you can't breathe well. So blood analysis revealed an elevated C-reactive protein level. So what is C-reactive protein level? Let's look at that. So it is basically the higher your C-reactive protein, the more pro-inflammatory you are. So let's look up the Wikipedia real quick just to make sure I'm not telling anyone anything stupid. So it's an annular, it's ring-shaped. We can't just use normal words here. It's a ring-shaped pentameric, so that means there's 5 of them, protein found in blood plasma whose circulating concentrations rise in response to inflammation. So as inflammation is being increased in the system, you have more of these C-reactive proteins being produced in the body. So frequently they'll run tests on people, and this will be one of the biomarkers or signals that they look for. So she had elevated inflammation in her body. She had lymphopenia, which I believe is elevated lymphocytes in the blood. So, reduced levels of a certain type of blood cell called the lymphocyte. So it's not an elevated, it's I guess, penia. Yeah, so it's a lower level of lymphocytes. And neutropenia, which I believe would be a lower level of neutrophils, which are another one of the, yeah, a low number of neutrophils, which is a type of white blood cell. And if severe, significantly increases the risk of life-threatening infection. So granted, I think she's, I don't know if the lymphocytes and neutrophils, which ones are, if they overlap with B cells or not. I would need to, immunology is hard, so remembering all the different receptors and labels that they have for the different immune cells is quite labor intensive, so I can't remember that exactly. So I would assume it is possible that they were low because of her immunosuppressant, but I wouldn't be able to tell you. So whereas corresponding baseline values all had been normal. So considering the recent coronavirus disease of 2019 outbreak, and after identifying a potentially contaminating visit, the nasopharyngeal swab for real-time reverse RT-PCR detection of severe SARS-CoV-2, which is the culprit agent of COVID-19, this was ordered. So they did the PCR test on her, and it came back positive. So strict hygienic and in-hospital isolation measures were applied to reduce the risk of disease spread. So the patient fully recovered under symptomatic management over approximately 1 week. So blood oxygenation saturation levels remained above 96% during the entire disease period. Blood sampling around that time demonstrated a nearly complete restoration of the above-mentioned abnormalities. So keep in mind, this person had immunosuppressive therapy done on her. Granted, immunosuppressive therapy has many different ways at which it can suppress the immune system. Not all drugs will suppress the immune system in the same way. So she got an immunosuppressive therapy that specifically targets B cell production with the CD20 receptor on it. So that this isn't going to say that we will have a similar outcome if it was a completely different type of immunosuppression. So we should continue. So additional cellular immunology performed 1 week after the positive COVID-19 test showed unaffected numbers of CD4 positive and CD8 positive T lymphocytes, as well as natural killer or NK cells. So CD19 plus, which is, these are all different receptors, the 4, 8, and the 19. CD19 positive B cell levels were as expected with rituximab reduced to 0.3% of total lymphocyte population, and the normal range is 5 to 20%. So she had a reduced amount of the CD19 positive B cells. So I don't know. It really is, it's hard to keep all these immune cells in line, but I'm really glad that they have listed the normal range as well. So hypogammaglobulinemia, so having too much of gamma globulin in your blood, in the IgG subfraction was observed. And D-dimer levels, which is, D-dimer is a byproduct of, I shouldn't say a byproduct, but a waste product of the formation of clots. So if you have a lot of clots and those clots are breaking down, those will be seen as D-dimers if they run a blood test on you. And these were elevated, so she had a pro-clotting environment within her body as well. So, and this is in accordance with previous data in COVID-19 patients. So, she had some white blood cells that were in the correct range, and she had the immunosuppressed blood cells that remained low. So it's not as if when the disease came, that it ended up progressing, becoming more severe. So what this is telling me is that even even an immunosuppressed individual with this particular type of immunosuppressive therapy, it doesn't appear to make the disease much worse. That's what I'm getting out of this. So, discussion. We present the first report of a patient with MS who was formally diagnosed with COVID-19 and experienced a favorable clinical outcome despite immunosuppressive therapy with rituximab. SARS-CoV-2 is a highly virulent pathogen with a considerable case fatality rate, notwithstanding extensive global effort. So presumed risk factors for severe disease with development of acute respiratory distress syndrome, or ARDS, include diabetes mellitus. So these are the comorbidities. So diabetes mellitus, which means sweet urine, arterial hypertension, so having high blood pressure in the arteries, heart failure, and chronic pulmonary disease. So these are the risk factors that we are looking for right now. Upon entering the body, the coronavirus rapidly infects alveolar epithelial cells through the ACE2 receptor. So toll-like retinoic acid inducible gene 1-like and pathogen recognition receptors play a role in initiating viral clearing by activation of downstream elements such as nuclear factor kappa beta, interferons, and interleukins. Okay, so a lot to unpack here. These are just downstream chemical messengers that are being produced to help signal to other immune cells what the heck they need to do. So, toll-like retinoic acid inducible gene-like and pathogen recognition. I think that's all I should say about that. So these innate immune mechanisms are not expected to be deeply affected by rituximab, given its specific mode of action. So remember, rituximab attacks CD20 plus. It specifically targets B cells. So you have different immune cells that are also working, but rituximab is attacking specifically the B cells, but may become easily overturned by SARS-CoV-2, as for instance, but this may become easily overturned by SARS-CoV-2, as for instance, the N protein located at the genomic level is a powerful antagonist of the host interferon system. So I don't know what the N protein is. Let's look this up. That might be the envelope protein, the nucleoprotein or nucleocapsid protein. So this nucleocapsid protein might be able to antagonize the host interferon system. So maybe it looks similar to one of the interferons. I wouldn't be able to tell you exactly what that means. So CD8 positive T cell counts can rise up to 80% of total inflammatory cell production in the in the pulmonary interstitium, and I believe this is within the lungs. Yeah, so it is a collection of support tissue within the lung that includes the alveolar epithelium. So CD8 positive T cell counts rise up to 80%. Rise up to 80% of total inflammatory cell populations in the lungs during COVID-19, which is emphasizing the importance of this cell type in host defense. So corresponding values were normal in our patients. So it looked as if the CD8 positive T cells were normal in this immunosuppressed patient, which is good if these are playing the biggest role in attacking the virus. So corresponding values were normal in our patients, likely contributing to an effective adaptive immune response. Humoral factors mediated by the activation and maturation of naive beta B lymphocytes. These are critically important to establish long-lasting immune recognition, but could be less significant in the initial antiviral response, translating to a good clinical recovery despite medication-induced B-cell lymphopenia. So here they're arguing, which is what I was arguing earlier before I even finished reading this paper, is that This is attacking B cells. It's not attacking the T cells. So the T cells are going to be the ones that attack earlier, but the B cells, like think of memory B cells, they are going to do more of their effects later. So even if you kill the beta cells, or sorry, the B cells, then you are going to still have your T cells, and the T cells can still do the acute phased attack, which, when it comes to a viral infection, that's like an acute viral infection, that's what you want. You want to still have those working. So, in another study, mice were infected with the related MERS, and a model was created with animals deficient in T cells, B cells, or both. T lymphocyte deficiency was associated with absence of viral clearance. So if they removed the T cells, the mice could not remove the virus, whereas mice lacking B cells were able to overcome the infection. Theoretically, it might be hypothesized that some forms of immunosuppression offer a protective effect versus the cytokine release storm observed in COVID-19. So this is something that might be very important to look at, is that maybe we do want to suppress the immune system. Maybe we do want to do that, but we might have to time it correctly, or we might have to attack only a certain part of the immune system. And here they're arguing, here they're saying, well, maybe we want to keep inflammation down. So maybe we don't want to have too much of these B cells around, especially if they're spewing out their pro-inflammatory cytokines. Maybe we just want to have the T cells there, and maybe we only want the T cells to be alive and attacking because they are going to be the ones good at attacking in the acute early phases. But the B cells, maybe we don't want them to work. Maybe they are causing undue amounts of inflammation. Maybe we still want to have some form of immunosuppressant therapy, like what these corticosteroids do. They suppress the immune system to a degree. Maybe we want to, if we can be smart about it, if we can learn from who's getting the serious disease and who is not, maybe we can learn from that to target the immune system in an intelligent way. Continuing. Hence, certain cytokines such as interleukin-2 and 7, granulocyte colony-stimulating factor, and tumor necrosis factor alpha, these are upregulated during infection and are associated with adverse outcomes. For example, the need for the ICU administration in affected subjects. So modulating these pathways might prove beneficial in the approach for this disorder. Yet, the precise role of rituximab in that regard remains to be elucidated. So invasive viral disease has not emerged as a major concern for clinical trial development and post-marketing surveillance of anti-CD20 therapies in individuals with MS. Invasive viral disease has not emerged as a major concern from clinical trial development and post-marketing surveillance of anti-CD20 therapies in individuals with MS. Nonetheless, many national guidelines are currently recommending suspended dosing where possible because of the COVID-19 pandemic. Maximizing risk avoidance during a global infection threat seems reasonable, but we must remain equally vigilant for the return of disease activity in highly active multiple sclerosis. Our findings illustrate that SARS-CoV-2 infection does not necessarily translate into a poor prognosis in MS patients who are receiving B-cell depleting agents, and are in line with recent reports of mild COVID-19 in subjects treated with ocrelizumab, which I believe this would be another antibody-related one. So I think if a drug ends in AB, that normally indicates that it is an antibody. But let's look at it just to see if I'm just spouting bullcrap or not. So yes, this is an antibody, and it is also an anti-CD20 antibody. So yeah, I am right. So these people are arguing that it's in line with COVID-19 subjects that were treated with ocrelizumab AB. Excuse me. Wow. So additional data and more extensive evaluations, however, are required to make a more firm safety claim, and for a number of reasons, caution is warranted before generalizing our observations. First, rituximab and ocrelizumab are occasionally associated with severe neutropenia, so having too low neutrophils in the body, and or more profound hypogamma-globulin hypogamma-globulinemia. So I believe this is too low of antibodies. Wait, yeah, it's a lower antibody count. So having too little of the gamma globulins. So yeah, I'll get back to that later, possibly. So this may impose an additional stress on the immune system. Second, our patient had none of the other medical risk factors for worse COVID-19 prognosis and was a non-smoker. So this particular person, well, for one, she was young. She was only 33, and she did not have other known risk factors. So if her only risk factor was multiple sclerosis, and if she was otherwise a generally healthy person, maybe this wasn't one of the risk factors that will ever do anything. But granted, there could be the possibility that this woman had treated multiple sclerosis. She was well managing her multiple sclerosis. She was going to the hospital. She was going to the clinics to make sure that she got a good medication, or that they were monitoring her symptoms. If we had people walking around right now with undiagnosed MS and we're not treating it, maybe they just thought that they have, maybe they just feel numb every once in a while. I don't know all the symptoms of MS, but perhaps they were getting, maybe they have undiagnosed MS, so they're not under an immunosuppressive therapy, and then they get COVID-19 later. That could theoretically be normally a comorbidity, but if it's treated, maybe it's not nearly as much of a comorbidity. That's something that we're going to have to discover later. So continuing, third, B cell levels in her blood were no longer fully depleted at the time of infection, as the previous rituximab administration dated from more than 4 months before. Okay, so third, the B cell levels in her blood were no longer fully depleted. So is 0.3%? I assume that is the depleted area, or the depleted concentration. Not my field of expertise, so just keep that in mind. So it is possible that her B cells were able to re-ramp back up by the time she was infected. So fourth and finally, a uniform dosing scheme exists for ocrelizumab, but this is less the case for rituximab, where, for example, 6 monthly intravenous courses of 2,000 milligrams are not uncommon. So there's a lot more variety in how rituximab is administered to patients. And so you have less control of this variable. So maybe the concentration that she got, which, remember, she only got 1,000 milligrams, and that was only done once, she was okay. But perhaps someone who has the six monthly IV course of 2,000 milligrams, maybe these people have more immunosuppression and then become a high risk factor. We don't know, but we do know that in ocrelizumab, it's more regulated. The administration is a little bit more uniform, and so at least with ocrelizumab, they're showing similar results. So at this moment, within the context of the ongoing COVID-19 crisis, we advocate for carefully balanced case-by-case treatment decisions, including monitoring of disease activity and CD19 positive B cell repopulation regarding anti-CD20 agents in subjects with multiple sclerosis. So with this, this is excellent news, actually, that at least it is excellent news to know that at least some immunosuppressants do not automatically make people much more likely to have a crazy disease progression from COVID-19. So what we can glean from this is that if we are targeting explicitly one part of the immune system for immunosuppression, and this particular part isn't known or isn't used for the initial attack for, say, an acute type of virus, then maybe the patient is going to be good. They are going to get through the disease well. And there might be a possibility, that this will actually be beneficial for people because they might not be producing the more pro-inflammatory cytokines and pro-inflammatory white blood cells down the line at the end of the disease. That might be good if we want to heal. For instance, when it comes to the administration of steroids for immunosuppression or for inflammation suppression, the timing is very important for that as well, because the inflammation can sometimes prevent healing from happening properly. So sometimes we want to have the inflammation in the first place to warn the body of damage. But we also want to prevent damage from continuing. So sometimes things like steroids, such as, what was the one? Dexamethasone, and then there's a laundry list of other steroid treatments. Giving those might play an important role at suppressing the immune system down the road. So this is good. This is good news. And we do know with the administration of those steroid hormones, the timing is good. So for instance, with dexamethasone for COVID-19, the people with the mild cases, there was no statistical significance. In fact, for people who ended up receiving dexamethasone versus not, but it was actually in the opposite direction. It seemed as if the disease progression might have been a little bit worse. There's the p-value was 0.17, so it wasn't statistically significant, but it was in the wrong direction. So that probably indicates if there is any benefit, I should say, if there is a difference, it's probably in the focus. If there is a difference, it's probably in the side of it being worse for people rather than better. However, when it came to the people on oxygen and the people who had ventilation, there was a significant difference benefiting those people when they were given steroids, which suppress the immune system. So here, we're probably seeing something along those lines as well, where you can cause immunosuppression, but it might not necessarily be bad. So with that, I'm going to head on off, but thanks for watching, and I hope to see you tomorrow.